So I studied about this subject a few days back when I got to know that I have to talk to both of you about this. And I observed that India's fertility shift is in course and is happening for a very long time now. Slowly and gradually this has come to a place wherein we can give it a percentage. It's 2.1 or 2.2, I heard. So India is actually witnessing a significant fertility shift, and with declining fertility rates, delayed parenthood, and challenges in conception, I think the questions that come up are really very crucial. From urban cities to towns, the question of when or even whether to have a child is really important, and it is being popped up everywhere. So the deeper question here is, are our healthcare systems evolving as quickly to support this new reality? And this is the topic of discussion, and it's my privilege to be joined by two distinguished voices. We have with us Dr. Rajni Mittal, a senior obstetrician and gynecologist at Hindu Rao Hospital, New Delhi. She has over 3 decades of experience in teaching and research. Then joining her is Dr. Urvashi Prasad, a leading public health and policy expert with over 15 years of experience, including her role as a director at Niti Aayog. Welcome, both of you. So to begin with, my first question would go to Dr. Urvashi. Dr. Urvashi, I would like to know, and would like all others here present to know, that when we talk about fertility shift, what this actually means, and does this actually have a direct impact on maternal care?
Yeah, thank you, and pleasure to be here. I would be addressing this from a public health perspective, policy perspective, and of course my own experience as well. I think, yes, definitely if you look at the total fertility rates, which is what we quote most often as data points, they have stabilized for most of the country, which means they've reached roughly the replacement level of 2, as you were saying, 2.1, 2.2. There are some states where, which are still outliers like UP and Bihar, etc. But for most of the country, it's actually reached that level or even gone below that level. And like you said, there's an important urban differential there, where maybe the urban, more educated woman is, like you said, choosing to either delay, having a baby, or choosing not to have one at all. And I think so long as it's a choice which is actually informed, it is totally fine, right? But I think our health systems, our policies are actually geared for a very different kind of scenario, where you have a woman who's typically getting married quite young, and then she's having her first and second pregnancies along a certain timeline. And now we are seeing all of that changing a lot. So it's important that our systems now sort of recalibrate to ensure that women have access to the right knowledge, the information with respect to fertility, when fertility starts to decline, when pregnancies can get more difficult. If they don't want to go in for that option, what are the other options possibly available to them? So I think information, access to these services, if I'm in a small town or village, I might not even have access to somebody who can tell me.
I'm sorry, but then we all have our mother-in-laws at home, and who I think they pretend to be more informative than any other internet source or other expert. So I don't think women in those areas or living in that setup get an opportunity to go out and speak to some expert.
Yeah, I mean, I think getting information from your mother-in-law is one thing, but speaking to an unbiased, neutral expert is totally another thing. And I think a lot of women don't have access to that still in the country. So I think we can actually say that it's a choice, it's an informed choice if I have all the knowledge and the access, and then I make a choice. Then you can call it a true choice. But if it's because I don't have enough information or I don't have the access to the right services, then it's a systemic gap then.
Dr. Rajni, my next question is for you. So since you have been in the field for more than 30 years now, you are one person who has seen this shift with your own eyes, you've experienced it. So how do you define it? And do you think it has a direct impact, or do you see that maternal health care is a reason to the shift?
Yes, I am working in a government setup. So previously what we used to see was more number of women coming in their, let's say 17, 18, 19, because they were getting married earlier. Now there's a shift, even from the poor socioeconomic status also, we are getting women in their early 20s, I will say. So there's a definitive age shift, and we all know that the total fertility rate we have, India as such has lower total fertility rate as compared to the global figures, and the, what I say, the replacement rate, that is 2.1 children. Total fertility rate means the number of children a lady is likely to produce in her lifetime. So when this figure touches 2.1, then it comes to the replacement rate. So previously, if we talk of say mid 1950s, it was around 6 at that time. And now it has declined to 2.1. We touched it in somewhere in 21, and now it is 1.9. And this is also not equally divided. So what we are getting, and with more number of hospitals coming up in our vicinity, so the total number of patients coming for the deliveries are reducing. Moreover, I am seeing that when I was doing my post-graduation somewhere 30 years, more than 30 or 35 years back, that time there were not many hospitals in the periphery of Delhi, mainly government hospitals, say Lady Harding, Maulana Azad Medical College, Safdarjung and AIIMS. They were the main hospitals. So we used to get patients from the periphery. Every alternate day we used to get the patient of obstructed labor with ruptured uterus because the labor was neglected. The ectopic pregnancies, because ultrasound came very late, somewhere in mid 80s, and that to only a few centers. So ultrasound was also emerging. I did my PG in 91, 94. So every other day we used to get rupture ectopic, rupture uterus, and like transverse lie with hand prolapse. These are all very severe conditions where the maternal and the baby's health is compromised. It may lead to death of the mother or death of the baby, or even if they survive, they are met with severe complications. So now what we are getting is, we are getting all these conditions diagnosed early in the pregnancy. So we are hardly getting any rupture uterus now. We are hardly getting, though we are getting rupture ectopic, but lesser. Because we are able to diagnose these conditions because of emerging healthcare, more number of hospitals, ultrasound available, and almost all the deliveries are institutional. Previously, when we used to inquire the patients, they used to say, previous all home deliveries, and DICE used to refer them to us. And now, it is only institutional deliveries.
So broadly, you are saying that we are actually into a phase where we can manage this fertility shift.
Yes, we are managing this fertility shift because of a good antenatal, intranatal care, and diagnosing the complications much earlier and managing them. We, like the maternal death rate, if I say in 92, 94, there were around 457. We used to certify death every third, fourth day of one lady in Lady Harding Medical College. Now there's hardly any death in a month, and the death rate has come down. We used to have one lady of almost as white as this board here, like hemoglobin of 2 grams much earlier, and now 8 gram we used to say, no, she is not anemic, because the prevalence of anemia was so much. And the severe anemia also we used to get so much. Now it is hardly, majority of the women, even 8 gram we consider anemic. No, we have to admit, give her iron therapy, or so that the hemoglobin is built up. So there is a difference in that also. The maternal death rate has come down. Heart disease we used to see so rampantly previously. Now we hardly see any rheumatic heart disease.
Dr. Urvashi, do you agree with her? Are we ready for this fertility shift? And also, would like to add one more question to it. Since this fertility shift has been is being seen for a very long time now, but its effect will come in course of time. So, what about the demographic change that we'll see in some time?
Yeah, I think undoubtedly we've made great progress on maternal mortality, on ramping up our institutional deliveries. But I think the journey has to start much earlier when we look at fertility now. We have to have conversations, and women should have that opportunity from an early stage to actually have those discussions around fertility. And I think there are many women who are invisible from these conversations, including someone like myself. I was diagnosed with stage 4 lung cancer in 2022, and while people like me in the West still have options, you know, they're still going in for babies, they're through surrogacy or adoption. In India, we just close all the doors on women like me, you know, which is deeply unfair. Because now younger and younger people in our country are being diagnosed with serious chronic conditions. So we cannot afford to just invisibilize them and just look at this typical fairly healthy woman. There's women of all kinds with all kinds of challenges, and fertility discussions, maternity, motherhood discussions need to extend to all of them. And I think our health system, our policy system currently largely ignores them. I mean, I was diagnosed in the national capital and nobody spoke to me about any option that I might have had before starting treatment or even otherwise. So it just goes to show, you know, probably what is happening to women across the country. So I think that is something we're not yet prepared for, and we need to be prepared for, because we can't just exclude a very large chunk of women from this conversation.
I wouldn't say sorry to know about your medical thing, but
That's
I
all
would
right.
say thank you and congratulations on overcoming it so, I mean, in such a good way. And Dr. Rajni, what do you think is the impact of this shift in fertility rate on women's health, on maternal health? We all know that it might have a harmful impact, but are there any benefits also?
Yes. Now with a decreasing total fertility rate, it means there are fewer pregnancies. The lady is exposed to fewer pregnancies. So as each pregnancy is associated with certain risks, so the minute a lady is exposed to fewer pregnancies, so she has to face fewer complications associated with any pregnancy. So fewer abortions, fewer cases of anemia, fewer cases of obstructed labor or difficult labor or bleeding after the delivery or cesarean section, that way. So absolute numbers, they are reducing. So that is one benefit, and there's more access, more institutional deliveries, because whatever resources we have, we are able to cater to that population. If every lady, let's say the birth rate becomes 4 times of what it is now, then our services will become 1/4 for individual lady. And with now with upcoming that there is a change in the pattern, that the women are getting more educated, more independent, financial independent, more involvement in the workforce, and later marriage, so with better finances, so they have more access to the healthcare system. So overall improvement in the maternal health is there. So that is definitely an advantage. So lesser abortions, lesser complications, lesser death rate, they all go hand in hand with that. But it has some disadvantage also, like with advancing maternal age, more and more elderly women, we see that there is rise in the pregnancy rates in the women who are more than 35 now. So because of the education, career orientation, and late marriages and rising costs, and they know that previously what used to happen was that if 5 children are born, 1 or 2 may die, so I will be end up having only 2, 3 children. Now with reducing infant mortality, we are able to save most of the babies, and so, and the rising cost, and they know कि even if I produce children late in the life, I have the option of IVF. I will always go for test tube baby. So I will go for cryopreservation of my eggs. I will produce children when I'm 45. Let me build my career. So this pregnancy in elderly women is not free of complications, because by the time they are 35, 40, they develop some medical illnesses. They may develop high blood pressure, diabetes, or some other medical illnesses. They may resort to smoking or alcohol, and with a fixed mindset, because in younger age it is comparatively easier to counsel. With elderly, it is no, it is my life, I can sort out. I have gone through a lot in my life, and now I can. And besides that, there increased risk of genetic malformations also, because after the age of 35, there is rapid decline in the quality of eggs. So we're likely to make with more genetic malformations, so they need more screening. So increased cost of the healthcare of each pregnancy with that is also there.
I'll come back to you and talk about the mental effects a lady or a woman would go through during all this course of time when she's going through all this medication and treatments. But meanwhile, Dr. Urvashi, when we talk about delayed pregnancies, when it's a choice, it's a good thing. But when it's not a choice, like you said that you were not informed the better ways to conceive at the right time, if you were informed properly, this wouldn't have happened. So how do you see our system, healthcare system is in place to change and to adapt with this new problem?
Yeah, I think that's where I was saying that, these conversations need to happen much earlier. We focus so much on just starting from the antenatal part, but it actually has to go even before that. And I think in urban settings, maybe more and more women now have access to these services. But like I said, in my particular case, I was right here in the heart of the capital, and I'm as informed and aware about these things as anyone can get, and I still did not get any support.
Do you still see there is a gap?
Yeah, there's a huge gap. And in India now, the chronic conditions are actually happening at much earlier ages. People in their 20s are getting it, people in their 30s are getting it. So it's not necessary that now these are just old age problems, right? So we need to start engaging with those women as well, and women in general at much earlier ages and stages. And I think our systems have not quite been designed that way. If I look at our public health system, or when an ASHA worker or somebody actually engages with a woman on this, is typically much closer to that reproductive stage already. So I am saying it needs to happen at least a few years before that.
So what do you think, how should we rethink of this framework, and what do you suggest, how should we go about it, go the way forward?
Yeah, I think, women wherever their interface with the health system is, and, not every woman would straight away come to a gynecologist, not every woman even has that access necessarily. So I think we need more fertility specialists as well. I mean, that's for starters one thing. And fertility of all kinds, including specialized like oncofertility. Oncofertility is a huge domain in many parts of the world now, but in India, you will struggle to find an oncofertility specialist. So I think fertility needs to be really invested in. That's a separate conversation altogether. It's a separate kind of specialization, training, and also sub-specializations within that. But I think generally our public health system, should, wherever there's a health worker having a conversation, say with a young girl, adolescent girl, these conversations should become more of the norm. Rather than an exception, and it's only when the woman comes in for an antenatal check, do we engage with her on this? It should actually be much earlier. Across the country, there'll be always some great centers of excellence, very, very good hospitals, very, very good.
But that notion is very urban-centric.
Yeah, and it needs to be like universalized, you know, for all parts of the country.
Dr. Rajni, I am really wanting to know that when you tell your patients to go through different ways to try for pregnancy, it might be IVF or some other way, the mental care at that time a woman should have, should get that support. How do you help that patient and what do you suggest for others?
Like when a lady is trying to, if it is a natural conception, then it's okay. Then she is concerned about her pregnancy health and her upcoming baby. But if she is not conceiving, because the infertility also is increasing in our country because of so much of stress, pollution, increasing cases of PCOS, obesity, and so many other advancing age also. And so if this with rising infertility, the lady who comes to us, because I see more number of patients of infertility these days in our clinics, and they all they are desperate to have a baby by hook or by crook. So we have to first of all counsel them that okay, relax, because stress is further going to worsen their infertility. So sometimes if the couple is not able to conceive, we tell them ki, and if the job is stressful, then we tell them ki, okay, take a short break, go for a holiday and just forget everything and just relax and enjoy, and maybe it succeeds also sometimes. And the family support comes here a lot, because the family should also be supportive instead of giving stress that by the, as you said, the mother-in-law decides everything. So the mother-in-law can be supportive in such case. So the family also needs to be strengthened. Yes. It doesn't matter if you're not able to conceive, ho jayega bachcha, koi baat nahi, wait karo, we will try. So these small words, they go along a lot, and instead of cursing, "Ki you are a useless lady, tum baanj ho," or giving such slangs to the lady, simple mental support, and on our end, we being doctors. So I think if we tell them that, okay, have a positive thinking, because positive thinking also changes our hormonal profile. It from cortisol to,
Yes.
it reduces the level of cortisol, and the stress is involved in everything in day-to-day life. So just think positive, and because positive thinking also brings a lot of relief, and do our work on our end. We are doing our work, and if timely referral to the IVF centers if it is required, that is also there. But we have to tell them the success rate, because they should not go with the false hopes, because going through IVF is also very stressful, that you have to go to the clinics every other day. And in Delhi also, the government setups, very few centers are providing
Ji.
IVF. So majority are private. So they are expensive, around 3 lakh rupees per cycle, with low success rate of only 30%. So we have to not build false hopes, but be realistic. So, and be hopeful.
Thank you so much. Thank you both of you for your insights, and it was lovely talking to you. Thank you.